thank you. Thank you all for coming. David thought I should just start talking about the book for a while and see where this goes. So this is the paperback. I didn't bring the hardcover. This is what the book looks like. I don't have to tell this audience that the AIDS pandemic is the worst in modern history. We can look at numbers: 76 million persons infected, 35 million have died. Prevention and treatment certainly has had a major impact on the pandemic, but it's been a long struggle. And Steve Inrig, does anyone here know Steve Inrig? He was a graduate from Duke, a historian. We wanted to tell the story of the struggle, for better or for worse, how governments and particularly the UN agencies responded to the pandemic over the course of history. And we start with the first cases in the early 1980s, and we take it right till today. So that's the gist of the book, but the focus is really on much of it on the World Health Organization's global program on AIDS, which I initially was involved, my first involvement in AIDS, and which really led the global response, beginning in 1987. This was way before the discovery of HAART treatment, which really was in 1996. It was a time when AIDS was a fatal disease, and the course of the pandemic was completely unknown. Now, remarkably, after 8 years after it was established, that program, the global program on AIDS, was shut down. With 1 year notice, at what we now know was at the very peak of the pandemic in terms of HIV infection. Why was it closed? It was concerns over the performance of the program, displeasure with the re-election of a very unpopular director general, and feuding between the UN agencies. So I directed this program from 1990 to 1995. I succeeded the very famous Jonathan Mann, who was the first director of the program, resigned precipitously in 1990, and died tragically in the Swissair accident off the coast of Newfoundland in 1998. Why did I write the book? Well, more than anything else, I wanted to tell the story about how 500 staff of this program worked tirelessly and with incredible commitment to confront AIDS in what was arguably the most difficult period in the pandemic's history. Remember, it was a fatal disease. There was no treatment. So the book covers that period, but it also covers before the global program on AIDS was established. When WHO's response, remember that was in '87, the first case occurred in 1981. And during that 6-year period, we cover that as well. At that point, WHO's response, if I'm polite, was cautious, although one could say it was really feeble. And then the book also covers what happened after the program was closed, and its successor, which you all probably know about, UNAIDS, was created but faced considerable obstacles and challenges. And then the final section of the book takes us up to the present after UNAIDS is well established. So the book, if you like, uses the global program on AIDS that I directed and as a lens to look at a 36-year period of the global response to the largest pandemic in modern history. The book does not cover it's a focus on low and middle income countries. The book does not cover what happened in the United States for the most part. So how do we go about collecting this information? How do you write a 36-year history? I am not a historian. That's why I had Steve working with me. And what Steve would say if he was here is that it's a very unconventional history for two reasons. One, AIDS isn't over yet. So it's like writing the history of the Cold War before the Cold War was over. That's one thing that's somewhat unique about this so-called history. And secondly, it's told with a participant observer, Steve would say, that's me, who had a unique perspective and had its own interpretation of events, and obviously who is invested in this interpretation, though my interpretation has certainly changed over time as the pandemic has changed and the global health community has evolved. It's a somewhat unusual, different kind of history. Now, how do we put this together? In 2001, 6 years after the WHO program shut down, I spent a month in the WHO registry going over all of my files, which were still there. All the paper was still there. Nothing had been digitalized. Nothing had been kept in a digitalized form. I conducted over 125 interviews with key players in the pandemic between 2001 and 2002. All of them were transcribed. We drew from 1,300 source materials and had input from 5 external reviewers. And the second floor of my house is still a mess. Hopefully it will get cleaned up soon. Now, the reason why we did all this is we wanted to get as many outside voices in this story to situate my voice. It was very important to make this a credible history. We had a small grant from the Kaiser Family Foundation. That's the only grant we got for help us collect information. So I'm going to quickly go over 3 things now that's in the book. Everything I'm saying here is in the book. I'm going to cover 3 aspects. The first is, what did the Global Program on AIDS face in leading the pandemic in 1987? Okay, this is, take yourself, or imagine you were alive in 1987. So, number 1, the disease itself, and it had been spreading in a devastating way, but it had been concealed. And why was that? Because there was a 10-year interval between infection and disease. And you couldn't tell who was infected. So what happened was, when programs started, it was a much wider problem than anyone realized, particularly in sub-Saharan Africa. And so the program had to play catch-up from the very, very beginning. Secondly, the disease at that time, and still today, but really at that time, had a topography of blame and accusation that hampered the interpretation of the disease, its causes, and its responses to it. We could say the words we often think of are stigma, discrimination, and denial. This was due to the groups it affected: men who had sex with men, injecting drug users, men with multiple partners, its modes of transmission, sexual intercourse, and illicit drug taking. There was also mother-to-child transmission that was somehow acceptable. The disfiguration the disease caused. You may have seen pictures of AIDS wasting syndrome or Kaposi sarcoma. And, of course, the presumed very real fatality. The denial was further facilitated by political leaders because of the 10-year interval between infection and disease. So the disease is concealed, and it's very much associated with stigma, discrimination, and denial. And then, as I already mentioned, WHO was very slow off the mark. The leadership at the time of WHO felt that the disease was a disease of rich countries, capable of responding on their own. The book has some very good quotes from the then Director General, Hofton Mahler. Also, the Director General was very reluctant for WHO to take on a social disease, as this was not viewed as a strength of WHO. That's his term, a social disease. Now, this all changed. Why? Because in 1986, at a very, very important moment in the history of the pandemic, the Minister of Health of Uganda stands up in the World Health Assembly and admits to the world that Uganda has a very serious AIDS problem. The first time AIDS had ever been mentioned in the World Health Assembly. After that, African country after African country had the guts to take the floor of the assembly and announce it too had a problem. Fourth, WHO not only was slow off the mark, its structure and operational capacities did not allow it, and still does not allow it, to respond well to such global health emergencies. And in fact, within 3 years of the program started in 87, within 3 years, there were concerns about WHO's ability to be an implementing agency, particularly in the African region. Now, the WHO Director General anticipated this, and so he placed the program in his office, like had been the case with the smallpox eradication program, and he gave it enormous latitude. However, Houghton Mahler refused to run again as Director General in '87 and was replaced by Hiroshi Nakajima as a more classical, traditional WHO Director General. And he wanted the program to be like all other WHO programs and be situated in the WHO regional offices. And I tried to assure our donors that we could still operate efficiently, but I could not convince them. Fifth challenge we faced was, how do you approach a disease like AIDS? There were fierce arguments at the time. Do you approach it as a health, medical, biomedical problem? Do you approach it as a development problem? Or do you approach it as a human rights problem? We tried in the global program to incorporate all of these in working with our UN partners, but we could not shake off the accusation that we were pursuing a medical model. We were the World Health Organization made up of doctors. Then, at the same time, the UN agencies wanted to be part of this, depending on whether you saw this as a development or a human rights issue. And so there became a fierce competition for resources between WHO, UNDP, UNICEF, and other UN agencies. And the donor community became very frustrated that all these different UN agencies were knocking on their door. And then all of a sudden in the 90s, we start to see a lot of AIDS cases. And the fear now is, what are we in for? And the UN can't seem to get their act together, even though WHO has supposedly been given the lead through the global program on AIDS. And then the ultimate closure of the program came about, as I've already intimated, when the Director General ran for re-election in 1992. John Mann had resigned as director because of his fights with the Director General. Jonathan really wanted a human rights approach. The Director General wanted a biomedical approach. He had worked for pharma. And Nakajima got reelected in 1992 under a real cloud, and there's tons of press on this, on suspected bribery and financial irregularities by the Japanese government. And that was, for the donor community, for them, the end of had any confidence that WHO can run the program. Now, despite these challenges, it's not all doom and gloom. If you look back, the program I ran and the 500 people that worked their butt off achieved a great deal. They raised awareness about the pandemic. They formulated sound policy, and there were no inhibitions despite the sensitivity of the topic. There was a broad range of prevention strategies. Technical support was provided to more than 120 countries. Many say this was the program's greatest achievement. There was an initial approach to care and support, even though there were no drugs. The wonderful partnerships were created with the non-governmental organizations and groups of persons living with AIDS. There was a research agenda started on vaccine and drug development, diagnostics, and epidemiological and behavioral research. And there were the initial dialogues with pharma on making ARVs available. And this is all documented in the book. So that's the first story, a major part of the book. What was it like back then? Okay, now the program is shut down, literally overnight. The program is shut down, and a new program is created, UNAIDS, a joint UN co-sponsored program. So what were the challenges that this new program faces? Remember, we're now in 95, 96. HIV rates the number of infections are in the millions. We're starting to see a lot of AIDS cases. The WHO program is shut down. So UNAIDS has to start scratch. And what were the issues? So for the global program on AIDS, there were 500 people losing their job, literally losing their job. People that had worked tirelessly for years no longer had a job. Now, some of them, and let me tell you, they worked right till the end. Some of them did get positions with UNAIDS, some found work elsewhere, but there were many that didn't, and this resulted in a multi-million-dollar lawsuit against WHO for breach of contract. And neither WHO nor GPA handle this very well, I will tell you. WHO was also faced with the issue at once it was decided by the World Health Assembly to create UNAIDS and shut down WHO. It was WHO's responsibility, and that meant me, to go around to the 5 other co-sponsors, UNDP, UNICEF, UNFPA, UNESCO, and the World Bank, and get their governing boards to agree to UNAIDS with the help of the donor community. Now, some of these agencies were very suspicious of WHO. They couldn't believe this was happening, and they did not want to give up their own programs, despite the fact that I sat in a room with the head of the 6 agencies and the Secretary General in the UN, Boutros Ghali, and every one of the leadership, every one of the leaders of the 6 UN agencies signed on to create this new program to really deal with AIDS. But when it came to the operations, the people in charge of these programs didn't want to shut them down. At the same time, those of you who know the history, this was at the end of the Cold War. And there was a real hope within the New York part of the UN, particularly the Economic and Social Council, that they could have a stronger role to play. There was this very interesting period of UN reform rather than the specialized and other UN agencies. So there was tension. Also, who would control UNAIDS? Would it be New York, Geneva, or somewhere else? So that's the tension that GPA finds itself in. What about countries? So as I mentioned, GPA was providing support to 120 countries between $200,000 and $800,000 a year for their programs. That stopped because in the construction of UNAIDS, there was no money for that. The UN agencies were each to provide money, but not UNAIDS per se. And that really caused considerable difficulty for the countries at a time when the pandemic was at its peak and likely, we don't have proof, but likely cost lives. For UNAIDS, imagine you become head of UNAIDS, and that was Peter Piot. His selection turned out to be a highly politicized process. It took months for him to be selected, and in the end, he had only a year to establish the program with the tensions between the UN agencies, an expanding pandemic, and the shutting down abruptly of GPA. The other thing he faced, as I've already mentioned, the UN agencies who are the co-sponsors did not all want to shut down their programs, and UNDP in particular would not shut down their program. They kept it going for 3 more years. And the WHO regional offices did everything they could to hurt UNAIDS because they had been insulted by the fact that WHO had lost the program. So you can imagine the situation. Remember, there's a pandemic out there, okay? Millions are dying now. And look what's going on in the UN family. And then, of course, the donors. So the donors, what did they do? So they didn't have to give the money to WHO anymore. And what they did was they decided that UNAIDS only needed about 60% of the budget that WHO had received. And so they did not give UNAIDS the support it needed. And it didn't really force the UN co-sponsors to act responsibly. Many felt, true or not, that their main goal had been to shut down GPA to build up their own bilateral programs. And that's therefore where their responsibility ended with the UN system. So I'll simply say here that UNAIDS, and we don't have time to talk about this at length, found its role. It took a while. The big discovery of ARVs and the work it did in reducing the price of drugs, advocating for access, was incredibly important. There is a book that Peter Piot wrote, if you're interested in this, called No Time to Lose, in which he describes the work of UNAIDS. And subsequently, of course, we had the creation of the Global Fund in 2002, PEPFAR in 2003. A lot more actors get involved. A lot of different kinds of tensions result, as I describe in the book. But UNAIDS continues to play its role, and today has responsibility for monitoring what many of you know are the 90-90-90 targets in ending, hopefully bringing an end to the pandemic by 2030. Okay, then lastly, let me say the most common question I'm asked is, what are the main takeaways of the book? What does this all mean for the future? So I'll mention here, first I'll mention 4 that are described in the last chapter. and there some of it is going to be fairly obvious based on what I've already said. First, that mounting a global response to a pandemic of the nature of AIDS, particularly one that's a fatal disease, presumed to be a fatal disease, is a complex process. It takes an enormous amount of effort to establish a program, recruit staff, raise resources, develop strategies, maintain momentum in the face of numerous challenges and media scrutiny. Now, we didn't have the world of social media and the 24/7 cable news cycle that you have today, but there was plenty of media attention given to AIDS. Shutting down the program, no matter what its perceived shortcomings, if you want to shut down a program, it really needs to be done with great caution and careful assessment of the consequences. And we talk about in the book that donor countries should not be impulsive when launching and supporting new programs and impatient when demanding results, and resist shifting strategies to pursue short-term objectives for complex problems. That's the first lesson. Second, and equally important, those responsible for financing and operating global programs need to be held accountable. The lesson here is that in the face of a pandemic, both the donor community and the international organizations need to live up to their commitments. There are many examples of this in the book. I've already mentioned one, the failure of the UN organizations to really live up to their commitment to UNAIDS, where this lack of accountability really wreaked havoc on the lives of vulnerable people around the world. Today in the world of AIDS, I will tell you there is also still today some lack of accountability and transparency. The solution has not yet been found to this, although things are better, mostly because of the availability of drugs. Third lesson is when you confront a pandemic, it's very unlikely in the future that we're going to have a magic bullet. We didn't have one for AIDS, and my hunch is for many future pandemics, we're not going to have a magic bullet. And so one has to address pandemics in a one has to think in a broad continuum way, from prevention and control to therapy and care. Remember that prevention is a slow process. It's difficult when you don't have a vaccine, and particularly in what we saw in AIDS, and we've seen it since in other pandemics or epidemics, especially when there's panic and discrimination. This really becomes a challenge. And what we had in AIDS and what we still have in a number of the issues around pandemics is the battle between the public health or medical model, the development model, and the human rights model. All these are appropriate. All of these need to be built into our strategy, and we need to. What we've really learned in AIDS is the importance of civil society and the private sector to be engaged in our response. And the fourth lesson we talk a lot about in the book is the future of WHO. Now, there's no doubt that WHO at the time lost a great deal of prestige when the global program on AIDS was shut down. Faced with declining contributions in its budget, that's continued over many years, hampered by what I would say an archaic regional structure, and crowded now by an ever-growing field of global health actors, WHO has struggled greatly now for more than 2 decades, really since the time of the dissolution of GPA, to locate its place in the field of global health governance. It has scrambled a number of times to reform itself in a more efficient and focused way, but the effects of these changes have yet to materialize. I can tell all of you, as I tell the students, it's certainly not the organization with the reputation and prestige that it had when I joined it in 1978. Its failure to respond adequately to the Ebola outbreak in West Africa in 2014, honestly, should not have surprised anyone. Many recommendations have now been made since then to improve WHO. We all have to hope that WHO and its member states have the courage and political will under the leadership of the new Director General to make the reforms and to do those soon. And then I would end by just adding 3 other quick takeaways that are not as apparent in the book, but I've thought a lot more about. One is what AIDS shows us is that diseases often reveal a great deal about social structural inequalities in and across societies. Vulnerabilities matter. Structural interventions are important. The rights of women, the poor, sexual minorities, race, ethnic minorities, and people engaged in socially taboo behaviors are essential to understanding and addressing pandemics, particularly one like AIDS. Health systems matter. We need to think about, when we respond to a pandemic, how to look at our response in a way that brings about systemic change in the delivery of care. Allies can be found in unexpected places. The rise of civil society, the religious community in AIDS really was a prime mover, and one we should be grateful for. And also, we need to remember that progress in this area may not be permanent in society. Sometimes rights can be expanded to marginalized groups in one generation or political cycle, only to watch these advances recede in the next. We're going through something like that right now in our own country. Second other lesson I'd mention is that science is really complex when it comes to a disease like AIDS. Obviously, evidence needs to drive interventions. We need to have measurable outcomes, but we also need to have humility. The Secretary of Health in the United States promised an AIDS vaccine in 1987. You can read about it on the web. We shouldn't have hubris when it comes to this kind of science. Claims of a quick fix or magic bullet bring hope, but then they can bring great disappointment. A third lesson we've learned with regard to science is scalability is really hard. That work in a small context may not tell us what will work in a larger context. And also that providers in epidemics need to know their epidemic and not have cookie-cutter solutions, and not rely on a single toolbox, which you often see today in a number of publications. And then lastly, the book was reviewed in the Lancet by Richard Horton. And those of you who have seen his editorial, his book review, he pointed out something that it was a little bit, I think, something we didn't discuss enough in the book, but I think it's dead on. And that is that, unfortunately, despite the best laid plans of science and systems, the truth is that programs and agencies are run by people. And people are not only noble, selfless, and humanitarian, but also flawed, petty, and territorial. And some of the greatest tragedies in the AIDS story, really, occurred not only because donors or systems failed, but also because people had petty differences or demands or cultural miscommunications, or they let those personal animosities affect the lives of millions. And just to quote Richard, we must pay attention to people, observe their imperfections, and protect us all from ourselves. So that's what the book's about. Thank you.
Thank you, Mike. So I'm going to ask you a few questions,
Sure.
and then for, say, the last 10 minutes or so, I'm going to turn it over to the audience as well, because I'm certain that they have quite a few questions to ask as well. I have now read your book twice, and I truly, and I got more out of it even the second time when I read it. It brought back a lot of memories of that time, a lot of walking skeletons, and a lot of fears and anxieties. You know, my own dissertation director died of AIDS. I remember this very well. Your book is really a mix of the historical, the institutional, and the personal. And with that in mind, I have just a few questions I wanted to ask. And I just want to start with a quasi-personal. Thinking back, you said, let us all think back to the early 80s. And I want you to think back to that time, and really back to the moment when you knew that HIV was going to be a pandemic, that it had devastating impact, even though many world leaders, including some in health, really were in denial or minimizing it. What went through your mind? What were you thinking about? What was it like? I mean, being in that position.
Tough question. You know, before I took over this position, I had worked for WHO for 12 years, running the diarrheal disease control program and the acute respiratory control program. These were programs in children less than 5 where we had very simple interventions and really had great success in reducing mortality. And suddenly I'm facing a pandemic of the kind that you've described and I mentioned. And I felt my first thing was I needed to learn. I had never worked in sexually transmitted diseases. I had never worked in a disease that was fatal. I was thinking one of the first things I did is I went to Uganda. I had to go. And the way it happened was Noreen Kaliba, who ran an organization called TASO, a very famous woman in the AIDS movement. She came to my office in Geneva one day. She just came, walked in. I'd only been in the position a few weeks. And she said, let's go. I said, where are we going? She said, we're going to Uganda. So literally, the next day, I flew with her to Uganda. And I had not really seen, I had heard about the pandemic. Of course, I knew what had happened in the States with Ronald Reagan and Rock Hudson. And that was Elizabeth Taylor. That was known, but I'd never gone to Africa. So this is 1990. And she takes me, we land, we get in a car, just go right to her clinic. And there were hundreds and hundreds of AIDS, people with AIDS. Hundreds, desperate for care. It overwhelmed me, and to see what was going on there was shocking. And I asked some of the AIDS patients, what do you need the most? And they said, we can't swallow, we can't eat. And thank God I had been trained 100 years earlier in infectious diseases, and I figured out it was thrush. I didn't know John Bartlett then. And I realized what they needed was just some simple gentian violet, or now you'd give an antifungal, but just something simple so they could enjoy eating. And my God, they were so grateful that we came up with that. And then, quick story, she took me to the hospital, and there were 4 or 5 patients to a bed. Really, there were no beds for all these patients. So I was walking around, and it occurred to me, I said to her, it was a Catholic hospital, Catholic nuns in the hospital, and I asked her, so how do you give out condoms? No, sir, it's sad, but we can't give out condoms. It's against the church. And then she said, but don't tell anyone. We give out condoms to people that are HIV positive, because that we don't tell the church that we do that. So I walk around the hospital, and I wind up in the lab, and there's nothing in the lab. So I say to her, so how do you diagnose HIV? There's no lab. She said, well, we just assume everyone has HIV. No. So I learned that we were going to have to fight this. What did I learn from that? We were going to have to fight this denial and this taboo, stigma. We had to be creative. We had to think about people and the kind of terrible tragedy they were facing. And we didn't have the experience in global health to know how to do that. And we didn't have the media, and we didn't have the tools you might say you have today with 7 billion people with iPhones, 6 billion people with iPhones. We didn't have that. So this was what I realized is after that initial trip is what a challenge this was going to be. And there was nothing to really go as a precedent. And I'll just tell you one other quick story. So when I took the position, soon after I took the position, there was an international AIDS conference in San Francisco. And you may know that was a conference where President Bush was supposed to come and didn't come. Bush won. And there was a mass demonstration when the Secretary of Health took the floor to speak at the end. But there had been a pre-conference that had been arranged for the Global Program on AIDS to talk to the world about what we were going to do about the pandemic. And I walk into this conference room, and I'm expecting 100 people. Thousands of people are in the audience, screaming, what are you going to do? What are you going to do? People are dying. What are you doing for us? What happened to Jonathan Mann? And then I noticed some of these people screaming were my own staff from my own program in Geneva. And I realized there that it was going to take a lot to get the confidence of leaders in the AIDS movement to feel confident in WHO because they had been so burned by so many governments and by so many agencies who had not risen up by that time to help them. So those, I'm just giving you a taste of some of the challenges, personal challenges I faced very early on in taking the job.
Sure, I understand. You know, I think now here I am a professor in global health. Back then, I was an active member of ACT UP, and WHO was the enemy at that point because they weren't doing a damn
You all
thing
know ACT UP?
from our perspective.
How many have heard of ACT UP? Not bad.
Yeah, but I still remember that, and sort of really from the activist perspective, a lot of fear and also a lack of information and understanding what was going on behind the scenes. But you know, speaking of the activists, the engagement of activists sort of in ARV development did make a difference in accelerating development. And I guess that raises the question, to what extent should and can civil society and activists be involved in response to diseases? And how is that, what is the role they could play best?
Yeah, I don't think there's any doubt about, in fact, I would say that if you look in the early part of the pandemic, including Uganda, the countries that responded well all had strong civil society, all of them, and including our own, and the activism, ACT UP, and other organizations that got the very famous decision by FDA to have a fast track for the development of AIDS drugs. It's why AIDS grants are reviewed today earlier than other grants, that same fast track. NIH has a special budget for AIDS. So that was all because of the lobbying that went on in the early 90s. And I think there's no doubt that activists are really important. And there's a story in the book, which you know well, we've talked about, where I went to a conference in Acapulco. There was a group formed of people living with AIDS, a global group of people living with AIDS with chapters in different countries. And they invited me to be their keynote speaker in their annual conference in Acapulco. This was in 1992. And I went there with all the good intention and hope that I could convince them that what we were doing in GPA was the right thing and they would help us. And I had a flight to catch at around 3 o'clock in the afternoon. And so around 1:30, I'm getting ready to go, and they announced that I'm not leaving. And they formed about 100 of them formed a circle and said, "You're going nowhere. And the reason why you're going nowhere is you need to solve the U.S. government's immigration law at the time, which kept HIV positive people out of the country. But if you were on your way to Acapulco, you had to go through the U.S. And many of them who had been HIV positive, they found drugs in their suitcases, and they treated them very badly. So they really hated the U.S. policy on immigration. And I was not allowed to leave until I personally guaranteed them that I could get the U.S. government to reverse this policy. Well, there was no way. And make a long story short, with the help of a couple of colleagues, I did get through and did get out and got to the airport just as the plane was taking off. But that experience, let me say, was so impactful for me to understand the depth of the suffering and the stigma and the discrimination that in those days HIV positive individuals felt. You need to have an experience like that to understand what it was like to be, I don't know if any of you have seen Angels in America, the play, or you've seen the movie, if you've read on the band Played On or seen the movie, or Philadelphia. Those are fairly good depictions of what it was like in those days. So I think your question is terribly critical in global health. And we've seen civil society, particularly with regard, say, to breast cancer. Now we have a fairly good movement with access to non-communicable disease drugs. No, I think it's like you want to get anything done at a university, you encourage students to act out. I think that
Yes.
I think it's the same. I think it's the same thing when it comes to changes in policy.
Sure. I think it's what you just cited is an example that I could maybe generalize a little bit. When I reviewed sort of the annotations I made in your book as I was reading it, one, I guess, the theme that came through loud and clear, and I never really thought about it before, was one simple fact, and that's that AIDS changed global health, period. Would you agree with that, and could you then elaborate on it?
I'd even say many people would even go further, David, and say that AIDS was the main stimulus for global health. What's some quick examples of that? Well, it was the first global pandemic. It required a multidisciplinary response. One had to be concerned about prevention and eventually treatment. It increased funding for development assistance sixfold in Africa and tenfold overall. It was a major impetus for funding. I mean, it was for AIDS, but it brought into the field of global health. You mentioned the advocacy and activism. That certainly, we had a whole new creation of a movement on health and human rights. We saw advocacy play a role in other diseases we've talked about. So and if you look today at many of the leaders in global health, certainly in this country, I'd say 2/3 of them came from the AIDS field. They moved from AIDS into global health. That experience in AIDS, in many ways, made them want to do more and spread their experience in a broader way.
Sure. And I think I want to give the audience some time, so I have just a couple of other questions I cannot resist asking, just based on a few things you said today. One, the WHO.
Did I sound harsh?
How can it be remade so that it becomes more effective and relevant, I would say as well?
Well, the first question is whether the member states of the UN care enough to change it. Because it isn't going to happen. There have been numerous efforts to change it, but mainly because of jobs that people get, it's been very hard to change the way it works. What's WHO's main problem? WHO's main problem is it has 6 regional offices. Each one of those regional offices has a regional director selected by countries in the region. And then it has a director general who was selected by all the countries in WHO, 192, I believe. Those 6 regional directors, they don't report to the director general. They do whatever they want. And 70% of the WHO budget goes to the regional offices, and some of it to the country offices. Can you imagine any business that would run this way? No. And there's no UN agency that runs this way. And the reason why WHO was constructed that way after the Second World War was very simple. The US government wanted it that way because the Pan American Health Organization had been created in the 1920s and was going to be the regional office for Latin America. And so WHO did not want to give up, the US government did not want to diminish PAHO's authority. So they said, oh, we'll have 6 regional offices. Nobody thought twice about what it would mean operationally. So if you really want to deal with WHO, you have to create accountability. If you're going to keep the same structure, you must create accountability at all levels, from global level to regional level to the country offices. Otherwise, there's no hope. You could also change the structure and not have these regional offices with any autonomy, like UNICEF does, which is by far the most efficient and effective UN agency, and have a very strong country offices with very excellent people selected to run them. Every single office in WHO in the African region is run by an African, because the African regional director needs to get votes from countries. So that regional director, I don't know if I'm going to say this in the UN or not on Wednesday, but that regional director gets his votes or her votes by putting those people in those plum jobs in those country offices. That makes no sense. And until we change that, I don't see how we're going to change WHO. I'm sorry. Maybe I've been at it too long, but I've talked to a lot of people, and I don't see it. I think the current Director General is already facing, if you follow the Lancet, similar kind of challenges that his predecessors have faced. And he is from Africa and a very astute person.
I hope you say it just like that, actually.
Okay,
just like
good.
So just one more question. As I read the book, I thought about, you're honest about both your successes and some regrets, things you would have done differently. I think it was a particularly sort of moving and telling important lesson for all of us, exactly how you ended with a quotation about relationships and interpersonal issues matter. But during that period when you were involved in this, what two-part question, what were you most proud of personally, and what was your deepest regret? And from that regret, what have you learned?
I was most proud that I worked with 500 people who were so incredibly dedicated at a really tough time to the pandemic, and faced enormous challenges and worked day and night to confront basically a pandemic of a fatal disease, and that was to me a great honor and privilege, and I think I learned a great deal about how to manage people in those kind of situations. I guess my greatest regret is that we were unable to adequately address the stigma, the discrimination, the denial during our period. Jonathan Mann was brilliant at it. I don't know that he could have done better. We really didn't see a change in the pandemic until treatment became available in the late 90s, and people had hope of living. And now AIDS is no longer a fatal disease. And maybe it's impossible, but I will always, it really took 20 years for the world to respond to AIDS in a serious way, and that's too long. And many people died, and many of you I know in this room, you mentioned, I have certainly had colleagues. My person I shared an office with at the CDC died of AIDS. Many of you in this room had parents or friends who died of AIDS, and that's the tragedy of it all.
Sure, thank you. Thank you, Mike. So first two hands that come up can ask questions. Shenglan, and there we are, 1, 2.
Or those who are viewing the live cast involved, and they will not be able to hear you unless you are speaking into a microphone. But have no fear, you will not be on camera. So please come line up. Thank you.
Sang Lang, please. Sang Lang is someone who had many years working in WHO.
Once again, congratulations on your marvelous book. First, before I make a comment, I want to apologize for being probably controversial and provocative.
Good.
I just want to make the conversation.
No reason to apologize.
Yeah, I just want to make this conversation more exciting and interesting. First is obvious. You were very supportive to establishment of this UNAIDS, and WHO closed this global AIDS program. When I was in Geneva, I had lots of versions of stories, as you could imagine. And did you think at that time, or WHO as an international community, think about the third ways, alternatives? For example, Stop TB Alliance, roll back malaria. And the third way may be more better, or I don't know, or do you think all these, infectious disease programs should have UNAIDS, TB, UN, malaria? So that's the first comments or question. Second, while I acknowledge that HIV/AIDS has been or was a huge pandemic in many parts of the world, such as Africa, some East Asia countries like Thailand or Cambodians. But I always think that the HIV/AIDS was not epidemic, pandemic in some parts of the world. It's like China, India, accounting for over 40% of global population. So HIV/AIDS in China, India, has never been a pandemic. If you use the same burden of disease or indicators, target, whatever you use. But because of the politics or political size of HIV/AIDS control or policy strategies, such a strategy has been distorted the infectious disease control or funding policies. For example, in India, TB, MDR TB is the most important infectious disease, not HIV at all. In China, hepatitis B and C, give you some numbers. China has 90 million hepatitis B affected patients. China has 15 million people hepatitis C affected peoples. And that's the number one. Number two, then third is TB and MDR TB. But because of these politics, all these donors went to India and China, gave money for HIV/AIDS. Among these infectious disease patients, I found that the HIV/AIDS affect people lucky. Why? I met some congressman, woman. I met a member of parliament in British government. They said, you know, while the poor people suffer from HIV/AIDS, but also there are rich people suffer from HIV/AIDS, like David, your supervisors. Okay, but among these rooms, many people saw, oh, I know some people, they died of HIV/AIDS, but not many people actually really know personally people died of TB or malaria. So that's why, you know, HIV/AIDS resources has actually distorted, you know, other major infectious disease in other parts of some parts of the world. So that's any comments from you?
Those are great comments, and we don't have a lot of time, but I'll answer them. The first one, Shanglang, I was not supportive of UNAIDS personally. What happened was that our donors, and I describe this in detail in the book, without my knowledge, had a secret meeting in London. And at that meeting, 12 of them made a decision they were going to close down UNAIDS and create a new entity. And the formation and the description of that program was formulated by the Americans, the Brits, the British, the Canadians, and the Scandinavians. And they presented a resolution at the World Health Assembly I didn't even know was coming. And so this was a very tough issue. And as I mentioned, the reason why they went with the structure they went with was because the other UN agencies had successfully lobbied to have the co-sponsored program. It wasn't like we had an opportunity to look at too many other options. So you're right, though. Today, one might have come up with a different scenario. And I will also, talking about regrets, I also regret that we did not figure out a way, even in this new structure, to keep WHO much more in the game. The problem was the great distrust that existed for that Director General because of suspicion around his second election. So I understand exactly how you feel about that. I'm just trying to tell you, and I describe in the book, why it went the way it did. Now, the second issue of AIDS exceptionalism. This is a major issue. And of course, it is related back to, David, your point about activism and the enormous influence that AIDS activists had on governments, because suddenly a presumed fatal disease became treatable. And that led to an enormous effort to get drugs out, to keep people alive. And yes, Shanglang is dead right about the data, showing that the emphasis that was put on AIDS exceptionalism was not entirely correct. Now, there was a shift, as Shanglang knows, in 2002, when the Global Fund was created. It also addressed TB and malaria. Now, is that enough? No, but it is still a major player, and more of the money for TB and malaria, more of the money that goes for TB and malaria comes from the Global Fund than it does in AIDS. So I think that the percent of money that goes to TB and malaria is much higher when you look at what the Global Fund gives. So there was some adjustment made. Now the question is, where do we go from here? And I think it's not too late, Shanglang, to ask your question, okay? Because how long do we keep this up? What about maternal and child health? What about reproductive health? What about NCDs? All of these are very deserving of the kind of attention that AIDS got. But now we're in a bind because I think the last number I saw was something like $26 billion has gone, or $30 billion has gone to AIDS. And so the donor community doesn't want to quit. They want to see a successful end with some kind of epidemic control. And that's where this 90-90-90 targets come from. So I think that all of us should leave this room thinking about that last issue, because global health now has to be far more broad in the resources it needs, and we're at a time in our history where global health has never been more threatened in the United States. Now, thank goodness China has really stepped up, and some of you know that Germany is really stepping up, and we are no longer going to be, unfortunately, if the things continue the way they are, the leader we were in global health. Unless all of you in this room remember when you go to the polls that global health really matters. Because there's no way the U.S. will maintain its current commitment unless there's a change in this country. But even so, we can count on China, we can count on Germany and the European Union to continue to support, but it cannot just be an AIDS movement, as Sheng Lang has said. These are two outstanding points that are addressed in the book, and the second one in particular we all need to keep our eye on.
Thanks, Tim. Just one more question. Yes.
Sheng Lang, those weren't controversial. Those were outstanding questions.
Yeah, my question is nothing like that. I do not have a very large background in global health at all, but any means. But you were pointing to the successes that your group had in, I guess, setting networks and training and getting communication out to countries from the WHO to the countries that were most affected. Can you speak to those programs and how establishing those networks without a precedent went in the beginning, and how were they scaled, and have you seen them applied in any other field?
I think the networks, as I already intimated, the networks that mattered the most were the civil society networks. NGOs, you should have seen the work of the Muslim leaders in Uganda. You would have been very impressed with what they did, okay? There are numerous examples of business communities. In Zambia, almost all the people in the government, in the leadership in the economic sector died, and the banking sector really stepped up to help. So I think that the truth is also involving people with the disease. I think that has made AIDS particularly unique, although we've seen this now in other diseases, because they can speak the most with the most passion and knowledge about the illness.
I'll let you sneak in.
Thank you so much, Dr. Merson and David. My question is more your comments. I mean, after all this long career that you have on global health, is of course true that the AIDS epidemic has helped to build health systems across the world, mostly in the world in development. My question will be on how the agencies, the global governance on health, deals with issues of private interest, vis-a-vis the development of drugs, pharmaceuticals, corporations, and also the fact that many of these new health systems look like the ones of the developed world, creating we can say, yes, access, but at the same time, increasing levels, demanding level financially to the member countries to sustain these systems in cases in which they cannot do it.
So I would say in brief that, and I don't want to sound like a softie, but I think the private sector learned its lesson quite a bit in AIDS. When the AIDS drugs became available in the mid-90s, it was $15,000 a year to treat a patient. And now, John, $100, $80 to treat a patient. And soon we're going to be giving a single injection every 3 months or every 6 months. Yeah. I mean, so I think pharma got burned really bad. If you had been with me in Durban in the AIDS conference in 2000, with thousands of people on the street screaming at the media about pharma, they learned their lesson, I think. And I think we see a lot more corporate social responsibility. I'm not saying there isn't greed out there. There are some companies that still charge outrageous prices for some of their drugs. Don't get me wrong. But I think, you might have seen in the press, you now can get a lot of the cancer drugs. I think 12 cancer drugs, a couple of the companies are going to make available at cost for the low and middle income countries. So I think my approach today is to work with pharma, to see them as a hopefully as a colleague and as a partner, and not as the enemy. I don't think they want to ever live through what they lived through, at least I hope they don't, around the turn of this century over the AIDS drugs. So I'm more optimistic than I might have been had you asked me that question 10 years ago.
All right, thank you. Thank you, Dr. Merson.